fantastic conference. Please sit down because our session is not over. In fact, the better part of the session is yet to come. So I invite all you people there. Please tell us if you heard sessions, speakers speaking here. Can we have some more mics in the all over? Please don't shy off. Come and say what you do differently. Please, ma'am, would you come up? Tell what you do differently. Some technique, something that you people do differently. Anybody? Please.
Thank you, sir, for inviting me. When we do SICS, it has got number of problems. How I have overcome these problems? While delivering the nucleus, many times with the pressure of vectis, the nucleus is just touching the endothelium. It leaves a lot of fragments, particles on the endothelium. How you deal with that? That is the biggest question. Because dislodging it is a bit difficult. Okay. Second problem was the construction of the tunnel, which most of the time it used to leave a large amount of astigmatism that is overcome with the biplanar incision, the stretching of the cornea and other things. And the third thing is this: how to when you extract the nucleus out of the tunnel. That time the globe rotates towards the 12 o'clock position or superiorly. So that another problem is there. And these two problems I have overcome with first dislodging the nucleus nucleus matter and the nucleus particles. I have used the jet of fluid from the Simcoe cannula or whatever the irrigation aspiration cannula to dislodge the particles. Just direct the jet of fluid towards the cornea and use small pulses of it. So all the cornea gets cleared of the particles. This is the one thing I have did. Second thing, while extracting the nucleus, use the forceps to hold the lower part at 6 o'clock, just like you do superictus suture. So hold the lower part and just remove with the vectis. That gives excellent control on the globe. Globe doesn't rotate. Otherwise, you have to hold the lip of wound, which always get torn because of a lot of force is needed. So these two modifications I did for my better SICS, and now I am encountering no trouble. Thank you, sir.
Excellent. So, just see, this is a problem that unstable globe, Dr. Saab mentioned, that the unstable globe, I mean, we all hold either the superior rectus or a forceps in the sclera that we have dissected, right? And we bring the globe down, put the vectis or any other instrument, and then direct it to the nucleus and then depress it. Dr. Saab has done this innovation where he holds the lower part. So, having held the lower part, I think the dynamics would be good. And I'll take this back home. Thank you very much. And the second thing that he said is to wash the nucleus, maybe kind of a delamination in the anterior chamber, if I have understood you right, with the BSS, so that the nucleus is kind of, the epinucleus is shredded off and doesn't stick to the endothelium during its extraction. Is that what you said? So
hello. The particles of the nucleus, they are too many, and so many times they obstruct your view.
Absolutely.
That is very important to dislodge them before.
You visually see more clearly what you are doing.
Yes, sir.
To add to this, please, I said, if the only difference that I find with my phacoemulsification cases and the SICS cases is a rebound if I stop steroids before 2 to 3 weeks. That is the only difference I find, and that is because there is a little trauma additional on the incisional front. Of course, with a harder cataract, there will be more energy trauma inside the eye with phacoemulsification. So if you irrigate the incision, we must all keep it in mind to irrigate wash the incision, because it's a triplanar incision. There is a scleral component, there is a corneal component, there are the pockets. So we need to clean them. If you have seen sometimes, accidentally in some case, a epinuclear fragment or a cotton fiber or something has been stuck in the side port. The patient keeps coming to us, either lal ho raha hai, thoda dard ho raha hai. So, when we are bringing the nucleus, these epinuclear shreds or the cortical shreds may be in some corner of this entire incisional component. So please wash them. This is the third tip that I wanted to give from my end. Thank you very much, Dr.
Thank you, sir, so much.
And we are waiting for many more to come from the floor.
I just wanted to add one more thing. Before that, I request Nath sir to come on the dais. You can ask question from here, sir. Dr. Dharmendra Nath.
धर्मेंद्र जी इधर आइए.
Dr. Dharmendra Nath. किधर है?
No, he's gone.
Achha, sorry.
Anyway, please.
Yeah, I just wanted to add one more thing.
Dr.
As he said, the irrigation of the tunnel is very important because small shreds can be there. I am using AC maintenance in all the cases, so that is the advantage. Most of the times it is washed out, but at the end of the procedure, I just swipe the repository in the incision again, so that something small, if it is stuck up, it should not create any problem. That also gets washed up.
Exactly.
I would like to add one more thing here. If you are doing side port, I think that is the best way to wash out whatever is there in the incision from the side port. That also helps.
Excellent. Dr. Madhuri's point.
Mic is not.
Multiple jet cannula, and that there are so many jets coming. If you flush it out, the entire angle gets totally clear and the tunnel also gets clear. Yeah, Philip, after your question, please come here.
No. Dr. Philip, please.
Yeah, I just wanted to thank Dr. Madhuri for a very inspiring talk. In fact, I did my first cataract surgery in 1974, even before doing postgraduation, and did ICC, ECC, then FACO, and then back to SICS. And 3 things I do slightly differently from other people. Number 1, making incision. I do entirely temporal, except when there is a withdrawal astigmatism. To correct the astigmatism, I do superior. But I would advise everyone to shift to temporal SICS because surgically induced astigmatism is nearly nil, below 0.5 diopters cylinder. And if there is withdrawal astigmatism, incise on the steep meridian, and it will really correct. It will correct if it is a superior one. If it is very difficult to, as in my hands, it's very difficult to correct against the astigmatism by temporal incision because it does not cause any surgically induced astigmatism. Number 2, the way I do differently is I don't make a conjunctival flap. I make a conjunctival scleral incision. And then bleeding is a little more, no cautery used. So the spot of incision is slightly different. It will be so that there is a mini flap formed by the conjunctiva to cover the incision. So then it helps in the healing. And number 3, 100% almost I use sandwich because when you do sandwich, you have an additional pressure, pulling pressure, so that the amount of incision required is about 1 millimeter less than normal. So these 3 things I do differently.
Right. Thank you, Dr. Phillips. Just to add more power to what Dr. Philip Kuruvilla just told us. On the astigmatic front, yes, I mean 65 to 75% of the patients would have ATRs as their component in the eye. So the pre-existing astigmatism, 65 to 75% would be ATRs. So definitely 75% should be temporal. We also go by Dr. Boromani, who says that we should be versatile enough to have give steep axis incisions so that we can correct surgically correct rather than induce astigmatism. And then coming to Dr. Madhuri's statement on that 0.75 astigmatism is kind of a multifocality. So, I mean, for village folks who are at home and are don't want glasses and have modest visual demands, we can always keep that use that astigmatism to advantage. And the second thing that you said, sir, that the direct conjunctival incision with the sclera, I've seen the vitreoretinal surgeons giving intravitreal injections. What they do is they actually take the conjunctiva a little forward and then give the incision. So what happens is the conjunctival incision and the scleral incisions are not on the same line. They are a little behind, so they have a cross overlapping effect. So definitely that is, it really adds value to the incision because, and that you don't cautery because there is less surgical trauma. Sandwich is a matter of choice to reduce incision. I think the way you bring out your nucleus, if you are happy, I think we can all continue doing that.
What
Yes,
is, just a minute, what is the incidence of conjunctival ingrowth? Have you seen any, Phillips? Conjunctival ingrowth, have you studied it?
You don't cautery the conjunctiva after you have finished your surgery?
No, I don't cauterize at all. There is no
Just
need
keep
for
it as
cauterizing. Just
it
keep
is.
it, it covers. It's like a mini flap is formed there.
So
and
rather
that
to
conjunctiva-
put Dr. Sahu's question in a different format, how many times would you see in the 7th post-op day that the conjunctiva is exposed and this scleral incision is visible?
Almost never.
Okay.
I mean, it's almost never because conjunctiva
So
is
that,
very loose.
That also, that apprehension is also dispelled with?
No, this conjunctiva is loose. So as you said correctly, then when you incise, it is in two different levels.
Yeah.
The scleral incision and the conjunctival incision, they are in two different levels.
Yeah,
so
if you
then
just
when you
take it a
open
little this
stroke
side
it,
and then
yeah,
give the
when you
incision,
stroke it,
so
if
it'll
conjunctiva
always
covers it, it makes an extra
think so.
protection for the scleral wound.
The
Conjunctival ingrowth, never, never.
The
But it would
conjunctiva
require a
and
little bit of practice. Just, you know, we are all experienced. I think if they are learners, don't readily jump into it because the half thickness incision on the sclera is very important. Because that half thickness of the incision, and mind you, we are giving that incision on a eye which is like this. And initially, you know, even the most experienced surgeons for any incision, even when we are talking, every time we are talking, we start slowly and then our voice opens up. So the first part of the incision is usually shallow, and because the mid part of the globe is more towards the incision, so then we become a little bold. So that is, and then, you know, again it is down in the nasal part, suppose it's left eye. So what happens, the premature entries happen in the center and the buttonholing of the flaps happen in the periphery. That is because the scleral incision has been varied in varied places. So, I mean, Dr. Philip Kuruvilla's suggestion is good, but we must be careful that a half thickness scleral incision, because that is the incision that will take us to the tunnel, the scleral tunnel. Yes.
Yeah, absolutely. I agree with you. You have to be careful. You should not jump into it because the correct thickness of scleral tunnel is absolutely important.
Sir, I have one question for Dr. Kuruvilla, sir. You are doing regularly temporal. I am also doing regularly temporal.
Yep.
My experience is that temporal incisions are little difficult to make compared to the superior one because sclera is quite thin there. Even fixating the globe with the tooth forceps, superior it is easy. Temporally what happens, many times the scleral fragment comes in the forceps. So many times you are tempted to hold the incision for fixating the globe. What is your, and the bleeding is little more on the scleral side. What is your experience?
Yeah, that is true. Actually, when I first shifted to, I used to do this superior incision for everybody, and then I tried to condense to make the incision smaller and smaller, and I came up to 3 millimeter. I haven't come up to 2 millimeters like Dr. Sahu. but 3 millimeters, and astigmatism was very minimal. But then it was a struggle. Then in one conference, a friend of mine said, why don't you do temporal? And then I started doing. Initially, it was very difficult, very difficult. But now, I prefer to do temporal. Even for in deep set eyes, temporal incision much easier than a superior incision.
Yeah, that is very
Deep set eyes. And then so I make it regularly. I use it, and I know there is a little problem there, holding it. But then it's okay. Even if you hold the incision, the scleral part of the incision, one part, it doesn't really matter, provided you're holding it further posterior, away from the limbus.
Right.
Secondly,
Thanks for the lovely tip.
for temporal incision, the scope of the length of the incision is less. And if you want to neutralize incision by temporal incision, you should have a longer and longer incision than the superior one, because they are comparatively weak in neutralizing. But because the vertical diameter of the cornea is less than the horizontal diameter,
Correct.
even if you want to have a very big incision, the scope is very less. You cannot have a very big incision. Superiorly, you can have a little bigger
agree
incision.
To Dr. Boramani.
From the astigmatic man, we will always take whatever he
I
says.
agree with Dr. Boramani. What he says was superior incisions for another one reason I prefer, except when patient has got a high astigmatism, because the lead is the best dressing, and then we don't have to worry about the covering the incision, and even you can take a little bigger incision when you are superior side. Temporal side, I think as he says, that it is always an exposed incision, it is not covered well.
It's
So,
theoretical, ma'am.
and
Theoretical.
And
Yeah,
thing is that
exactly.
when
But
you want to take
obviously, we have this carrying angle, and we have to negotiate, and then the sitting posture. So we need a little versatility to be Dr. Boramani, giving an incision at the steep axis, centering your incision on the steep axis all the time. We have to play around and go around the place. It is, but let us be astigmatic conscious. Yes, please.
Sir, MSICS itself is an economized surgery, both for the surgeon as well as the patient. But chota muh badi baat, I have been trying to economize it still further. I am performing Blumenthal technique, and in that technique, I have tried my own designed glide, which is prepared from my plastic visiting card, which is a strip that gets autoclaved, and it is a throwaway product for delivering the nucleus. And I am performing side port as well as the port for the AC maintainer by using 20 gauge disposable needle, and so I don't need any lens tip or MVR blade, and no need of viscoelastic also.
Excellent.
Thank you,
20
sir.
gauge needle, you said. 20
Yeah,
gauge.
by keeping the bevel down.
Disposable 20 gauge,
yeah,
the IV needles.
Yeah. So,
Excellent.
But
So you just
I keep
blunt the tips.
But I keep the bevel down so that there is no
you
avulsion
keep-
of the
Okay.
desmates.
Okay.
And it is giving good results, sir.
I was worried about the sharpness and it going and hitting structures. Because AC maintainer probably, to get a good AC maintainer always is a, Boramani is a difficult task, and
Sir,
it keeps in place. If you raise the bottle, it stays there.
Yeah. No,
That's
no financial interest, but AC maintainer from BD company are excellent. And I am using that disposable needle also from BD, which is costing hardly 2 rupees.
Yeah, I mean, that way. So we can also try people who are doing actually Blumenthal's AC maintainer, or that is the best way to do SICS, honestly, because even if you have caused a posterior capsular disturbance, nothing is going to happen because it's always positive pressure in the eye.
Yes.
The only time that you disturb that pressure is when you are bringing out the nucleus or the nucleus comes out. That's it.
Correct.
And rest of the time it's this, and the entire surgery is virtually visco-free. So, I mean, with the question mark to the kind of quality of viscoelastics that we get. So, all said and done, Blumenthal technique, there's no comparison. The only thing is, it is a little difficult technique to master because passive technique where you rely on the fluidics to bring out the nucleus. And of course, as Dr. Saab said, plastic, anything that is kept in the incision, not to prevent the iris or structures to come out and allows the lens to come out, is welcome. Sir.
I am Dr. Vilas Bidare from Baroda, and I must at the outset...
Sir, you don't have to introduce yourself.
I must congratulate Dr. Madhuri, because her fight is against a big giant like
Thank you very much, sir.
And I experienced the same thing, and my technique, surgical technique, was almost similar. Only difference was in that vectis, I made it a irrigating vectis, and we are using viscoelastics to pass through that. In those days, it was what was available was methyl cellulose only. So that technique we are using, and in I'm talking. I presented my first small incision cataract surgery technique at Calcutta in early 90s, and that time phaco was getting introduced to India, and we had a bandwagon of few surgeons who were calling a phaco ko phaco. Phek do. That was the movement we started, but ultimately phaco has conquered us, and I was a totally SICS surgeon, and I had to become a phaco surgeon then.
The times have changed
No,
now,
sir.
The times have changed.
To younger people in this house, let me tell you that Dr. Vilas Vidai has been teaching extracapsular PCIOL surgeries to almost every Indian, including me. You know, we have been seeing his videos way back in the early 80s when things were happening. So we learned a lot from him.
He has some tire technique also. For
yes.
nuclear removal, some tire technique also you are doing. That also I remember.
all basic steps, and those were, you know, expounding days when the IOLs first came and we didn't know what to do with it and how to go about it. And there were no videos. Very few surgeons had videos in their operating microscopes. You have to see from outside the presentations. What the surgeon actually wants to say wasn't clear. So the learning was much more difficult, and they are the pioneers who taught us then. Thank you very much, sir. And having said that, you know, he also told how it evolved. He went into SICS. And of course, you know, as the nucleus gets softer, see today machines are not a no-no, right? So if you can just go with the machine and just polish off the nucleus, that's fine. But then when you are in trouble, when it's a supra-hard cataracts and many other things, like Madhuri went the other way around just because she didn't have instruments on that particular day. So it's a very simple way of delivering very excellent results, and we are really happy to have learned all of it. Thank you.
Yes.
Yes.
That's the beauty of SICS, you know. There's a
Please
lot
come.
of creative ideas here, and many people have their different techniques. I think we should learn from everyone their way of doing it, not sticking to our own techniques. I think something beautiful can come out with taking up few things from each other. And I'm sure one day we will have a standardized SICS technique.
No, there is no standardization. Let it be full of
Lot of
innovation.
variations.
But you know, in innovation, never ever disturb a patient's eye. That's one thing for sure.
What I mean is,
Please
it's the
come, sir,
safe surgery, which
Yeah.
is the best, safest SICS technique. I think we can learn from each other and come out with that, so that the younger people will be attracted to this.
No, giving you industry figures. Industry figures today, we do 65 lakh cataract surgeries, so obviously these are traded in the market. And 18 lakhs of them are PMMA lenses. So 1/3 of our surgeries in India are definitely, for various reasons, SICS. There's no doubt about the fact. And then there are SICS surgeons with who are putting foldable lenses. So the gamut is huge. So this is obviously the first step to learning cataract surgery. There is no doubt about it, because it's so easy to supervise and so safe for a beginner not to disturb or jeopardize an eye or a patient's vision during the learning stages.
I want
Please.
to add one more thing. PMMA is perhaps the best material available for IOL. Only disadvantage is that if you have a small incision, the foldability is not there. Otherwise, if you see the PMMA patient operated 10 years back, through the slit lamp you will see that like a clear glass. All our acrylic lenses are having slight haziness in that. So material-wise PMMA is the best.
Today I was envying when I saw Dr. Haripriya giving those multi-piece PMMA lenses. Sir must have used so many of them. Now today there is hardly that those lenses are available, the PMMA multi-piece lenses, and they have their advantages in compromised bags, if you want to place the lens in the sulcus. All this, they have so many advantages. They're very versatile lenses. I think we must request the industry, let them take 100 rupee more, that's not a problem. Let them take 200 rupees what they take for a single piece lens. But let them come up with this multi-piece design. We must preserve the multi-piece design. You were waiting for something to tell. Please.
Sir, I do SICS under
Yes.
peribulbar anesthesia, sir. Sometimes, in some cases, I find that intraocular pressure is very high intraoperatively in the mid-surgery. So it becomes very difficult how to manage that, sir.
But do you do pressure checkup before operation?
I do manually, sir.
Then are you measuring the pressure before you
No.
take? So you better do that. It
No,
might
no,
be a
sir.
glaucoma case.
Preoperatively, we
No,
do.
no,
Preoperatively, I
it
do,
is
sir.
happening to
After
him rather frequently.
After giving block also, I check for the hardness, sir. But
You do-
during
you-
surgery it rises, sir.
So I used to have this problem, and I started to get information from people. Nobody answered anything. Iris prolapse used to happen. So I said it is very not good in my hand happening. So what I decided, I take IOPAR SR. This you know, before one day before, in the night you give one capsule, and in the morning before the surgery you give one capsule, and that has never happened. So this thing has come back. We are using earlier carbonic anhydrase, but we stopped somehow. Now you bring it back, and you have very smooth surgery.
I think he
It
has a
happens, sir.
very
It happens.
specific. Can I ask you at which procedural step do you see that the IOP has gone up? After hydrodissection?
After the CCC and hydrodissection, sir.
So probably there is a posterior misdirection of fluid while you are hydrodissecting.
Sir, how to
If you have to hydrodissect properly.
Sir.
Maybe if you are going, your microscope may not be good. Sometimes it so happens. If you go in front of the anterior capsule, you are bound to end up doing that. But even when you are going in the don't try to do cortical cleavage. Try to do cortical, or even delamination is fine. Because in SICS you can later on take out the cortex. So that is why I wanted to know where you want to, because probably you are having a problem with your hydrodissection.
Do you do side port?
Yes, sir.
Because our
I
zonules
do,
are
sir.
very permeable. There is something called, fluid misdirectional syndrome.
Just
Phaco surgeons face it quite often. So that is one thing.
What the other tell, the misdirection of the fluid, the iris can come up and block the side port, and the pressure goes up like mad. So visco, if you are using too much visco,
Sir,
you
I
have to be
would
little careful.
invite you to the dais, please. Please come. Please, it will be a pleasure for us to have you on
I
the
want to
dais.
add one more thing to this discussion of intraocular high pressure. Biday sir, you also may agree with me. Many of the senior surgeons, if intraoperatively suddenly the pressure rises,
Come.
they give
Dr.
preservative-free halocaine, intravenous, that is Xylocard.
Xylocard.
There is nothing in the published literature about this. But many of the senior surgeons are giving, and it works.
Intravenous.
Intravenous Xylocard, and it brings down the pressure.
Yes.
Dr. Boramani sir, I had a question. Like, we are aiming for the post-operatively near vision. So should we aim at with the rule astigmatism or against the rule so that the patient can read?
Against the rule, minus.
Minus
ATR 75, which Dr. Madhuri said, is perhaps my choice of post-operative refractive power that I want to have.
How much do we expect? It should be 1, 1.5, so that will help to maybe
1.5 is too much, but that blurs out distant vision.
Okay.
And also, you know, in the near part also the distortion is high. So if a person is having a operative astigmatism of 1.5, I would definitely try and bring it down by 75. Everybody would agree, you know, that 0.75 cylinder 90. You will see even in refraction, a person has come from his office and for a glass checkup, and he's 55-year-old, and he has a -1, 1.5, 1.25 cylinder, and he's worked in the office. He's come back and he said, "Where's your spectacle?" "Oh, I forgot to bring it." But I can't go without these spectacles because I'm good for distance, so I need for reading. So it happens. I mean, cylindrical powers definitely have some near vision corrections, very documented in literature also. There's not an issue. Now that the toric lens market has come, so we say that, you know, cylinders are very bad. It's not that perhaps.
Sir, this is regarding the anesthesia part, because most of them we face what we should use, a retrobulbar, starting from retrobulbar to topical.
I would now recommend, please learn subtenon anesthesia. It's
sir, that is, this is another term has been come up, this is parabulbar.
Yeah, subtenon is actually parabulbar.
Subtenous, you have to give nick in the conjunctiva, and then you go with the blunt cannula.
Go with the scissors, do a little split, and just there are cannulas, or you can use any cannula, and it works wonderfully. I tell you, I mean, our hospitals, we do 70,000 paid surgeries every year. Now, at 1 year, our endophthalmitis incidence was lower than globe perforations. Probably we had more myopic patients getting operated by us. In myopics, globe perforations are of the order of 1 in 1800. It is as high as that.
Great.
So if you are operating 1800, and for that patient, it is that patient. For you, that globe had to be perforated. Even with the most experienced hands, I mean, globe perforations, and see, 10-15% is myopia. So someday or the other, you are going to perforate globes. And today, globe perforation is something which we cannot with our patients operating at 6.669 vision, you can't afford globe perforation.
And can we use a topical for this
yeah, why
surgery?
not? I think many surgeons are operating topical, yes.
So, still the dilemma remains with us, what to use, parabulbar, subtenons, or this topical. So, what do you think that...
Topical with the intracameral Xylocard is my choice of anesthesia, actually.
I would like to add one thing
Please
here.
go ahead and do it, because, and first thing, let us learn subtenon. So, you know, if you're going topical with intracameral Xylocard, you use Xylocard, there's a lot of preparations available. I mean, if the anesthesia is not adequate, the patient is not comfortable, you can give subtenon on the table. So, I mean, that option is open. So, subtenon anesthesia is perhaps the thing to learn.
I would like to add one thing here. If you are talking about parabulbar, how many people have tried the medial anesthesia? I think that is the safest space to give parabulbar anesthesia. When you give, use a 26 number needle and just 3 ml of the anesthesia vertically near the canthus and this thing. caruncle, in between the edge and the caruncle, if you get vertically 90 degrees, just a 26 gauge needle, in that area there are no structures at all. That is the safest place to give anesthesia.
Yeah, obviously.
So this is the best way to give anesthesia. It is called as the medial anesthesia.
Still the debate goes on. I would like to suggest one thing. Why not form a panel for a safe SICS so that we can come out with the best of the techniques to prevent most of the disasters.
Yeah, you join ISM SICS if you are not a member.
See, it all depends upon each person. You see, there is no standardized technique. See, myopes, the advantage is the eyes are prominent, and so we can do under topical. So I do all high myopes under topical, SICS temporal. It is not very difficult. Only thing is that when you may have to keep on pouring xylocaine, but so don't pour xylocaine drops. It is just 2% xylocaine injection, take it in a syringe and a cannula and ask the nurse to keep on putting on the conjunctiva. Usually it works very rarely you will require intracameral.
The Xylocarda is very safe also. Because even if it goes intracameral,
yeah,
it helps in getting more anesthesia. So, sir, my request is that why not form a panel for preferred practice pattern for SICS?
AIOS is already coming up. I think Dr. Namrata Sharma, our Secretary General, was very kind enough. We came to Delhi, and I think the preferred practice pattern will come to all members.
And another I have suggested for suppose you are going direct from conjunctiva to the sclera, conjunctiva scleral incision. I have suggested to use a botropos the drop. A drop of it can coagulate. I mean, the further it helps in hemostasis, and it was excellently because it is in the past it was used for DCR also. It is safe for the eye tissues, and there is no problem. So it was my suggestion, Botropase from Jagat Pharma.
Jagat Pharma.
What is that you said?
Botropase. It is a hemostatic enzyme.
Botropase.
Yes.
DCR we used to use.
Harshul, would you add something to SICS? Do you do SICS?
Yes.
Please come up to the mic.
Thank you, sir.
Have you ever done SICS?
Yes.
Yeah, I do.
When do you do SICS today? When have you done your last SICS?
I think I do when I encounter a case which had very black cataracts, zonules are very weak, and especially if the cornea is also not clear, corneal opacity is there. So those are the cases where I don't get a good